What they said, any patient above 60, blood pressure more than 150/90, treat the patient, bring the blood pressure to 150/90, and it reduces the mortality. There's also evidence, there are a few classes of evidence. This class of evidence is about 2B evidence, which says setting a specific blood pressure. As I said, there's no specific goal target kept over there. You have to achieve 110, 70, something like that. Anything lower than 140 in this group provide no additional benefit. So that's the reason I said, you accept anything beyond 150/90. So do not stick to something, if the patient is having 140/90, start another antihypertensive drug. Just accept it, 150/90, because the study which has been done, there is no added benefit adding another drug, as there is no cause of morbidity or mortality which is increased. Of course, if you add up another drug, of course the cost of care, the cost of medicine will go for every patient. Now, in general population which is less than 60, now initially the patient which is less than 60 present most likely with the increase in diastolic blood pressure which has been seen. So anything which is more than 90, please treat it. And systolic, systolic, there are a lot of young patients, systolic blood pressure can because of various reasons, increase stress and life, everything. Focus on diastolic, decrease diastolic because it's more related to the vasculature. Now, recommendation number 4, population aged 18 years old. Now, this is the other recommendation along with comorbidities. Now, any patient 18 years or more with chronic kidney disease, initiate treatment 140 or 90. And again, as I said, there is no fixed goal targeted except anything beyond less than 140/90. Now, 18 years older with diabetes, same target. There is no difference. 140/90 start at 140/90, and anything less than 140/90 accepted. Now, the other recommendation about there were 8 recommendations, 6, 7, 8 is about choosing a certain class of drug, which I'm sure everybody is curious to know. What is the recommendation and what is the new recommendation about choosing class of drug. Unfortunately, in India, this recommendation is made by white people, American and Westerners. So they classify people black and non-blacks, which we don't discriminate here. What they say is, any people who is non-black, is like non-black population with diabetes, initial hypertensive drug should be a thiazide-based diuretic. Now, thiazide-based diuretic can be glutathione, can be hydrochlorothiazide, anything can be taken. The second, calcium channel blocker, which should be started. The ACE inhibitor is on the third of the list, and ARB, of course, is ACE inhibitor or ARB, never together. So they have recommended 3 classes of drug. One is diuretic, which was always there, and JH7 as well. Now they recommended calcium channel blocker and ACE inhibitor or ARBs. Now in black population, there are 2 classes of drug which is they have only recommended 2 classes of drug, either thiazide or calcium channel blocker as a first line of treatment. Now, patient with CKD and hypertension, what they say is start with ACE inhibitor. Of course, all the patients with CKD would be having higher creatinine. But having said that, patient with higher creatinine, you can very well start with ACE inhibitor because it has multiple, it has a good effects on heart, it's a good effect it's a pleiotropic effect, it's a cancer done on ACE inhibitor. So it is a very good drug and it has a lot of effect and a lot of good benefit effect on mortality and morbidity as well.
Is I think taken care of because now you have indigenously available minimal invasive surgery instrumentation.
Rate of change of GFR, rate of change of creatinine, and please tell the patient that you have to keep followed regularly for a few couple of days unless until you think it's not going to be changing much of creatinine. Now initially, and here which as I said, it's ACE inhibitor, ARB, never together, and it improves. It says it preserves kidney function as well. Any CKD patient, black, non-black, anything, this is applied to everybody. Now, the main objective of hypertension is to attain and maintain blood pressure. Now, if you start with any antihypertensive medicine and you don't call the patient every second day or third day, you call the patient about a month time and see how the blood pressure is faring off. If you see, the blood pressure still remaining same, it's not improving, the patient, maybe you check about the patient is taking proper medication, patient it died, patient taking, reduction of salt is there or not. It is very important, we give a lot of medication, we forget this. Patient had a lot of papa, achar, preservative foods, a lot of junk food, KFC, McDonald's, and unfortunately, this tend to retain a lot of water, increase the blood pressure. I had second drug. Initially drug what he said, depending on black, non-black, or comorbidity, non-comorbidity. Second drug can be thyroid type diuretics, calcium channel blocker, ACE inhibitor if it's not added previously, or ARB. Mind you, they have not mentioned about beta blocker here. And a lot of clinical trials has done, beta blocker has been shown a lot of side effect and not so much of a benefit rather than having benefit with class of drug. Keep assessing till you keep adding till you reach the goal. Now, if the BP cannot achieve with two drugs, add third drug. Do not use ACE inhibitor ARB. Now, three drugs which are always there, like diuretic, ACE inhibitors, ARBs, and calcium channel blocker. Fortunately, we have a lot of combination available today. You have ACE inhibitor plus calcium channel blocker, ACE inhibitor plus thiazide. Or one of the company, a lot of company also have ACE inhibitor, thiazide, and calcium channel blocker together, which is called triple drug therapy. And having said that, if you cannot manage the patient on an OPD basis, blood pressure still continues on the higher side, please refer the patient to a specialist. Now, there are differences with agency 7 and 8, already said, it is more of theoretical. Which I said, there were pre-hypertension guideline which was removed. They only said about thiazide, and now agency added about calcium channel blocking ARB as well. This is American guidelines, and this is guidelines. There are a lot of other guidelines, the European guidelines, the EDI guidelines, the NICE guidelines. Unfortunately, every guideline says about almost same thing nowadays. If you have if a patient who is more than 60 years old, start with one medication, target 150 or less than 150/90. If the patient cannot be maintained, add another drug. Please, but make sure the patient is compliant with drug, patient is compliant with the diet, and patient is doing some kind of physical activity. Unless until don't add a third drug just because you are in need to show the patient that the blood pressure need to be controlled. The patient also need to work from their side to make sure that the patient and doctor are the same level, managing it's not only doctor who is trying to manage. The patient also has to manage or hypertension as well. Now, the concluding from this GNC guidelines only offer what you need to know. Guideline doesn't tell you what you should do. Just stick to individualized patients. Stick what kind of patient is there. Some patient is just obese. Some patient have other comorbidity as well. Some patient have a lot of non-essential hypertension, as like some have issue with adrenal, some have other issues. Just make sure that you're not dealing with some other kind of hypertension which can be correctable. Make sure that you have. I just want to finish it off. What is the take-home message? Target should be individualized to the patient. Thiazide, diuretic, CCBs, ACE inhibitor, or the reasonable choice in starting therapy. You can start anybody of them. Do not combine ACE inhibitor and ARB, whatever the pharma company says, do not use it. Combination, anything beyond 150/90 today is acceptable. Thank you so much.
Thank you very much, Kumpagare, for an excellent presentation on hypertension. I call upon Dr. R.P. Sharma to present him a floral bouquet, and Dr. P.P. Chale to present him. And once again, sir, I stay collected, Dr. Sandeep Dwivedi. This lecture was sponsored by Titan Hospital. I call upon Mr. Chandrakant from Titan Hospital to accept the felicitation. I call upon one more sponsor from IME Pharmaceuticals, Dr. Rohit Kapoor, to accept our felicitation. Once again, the lucky draw time. Over to Dr. Sushi Sharma.
Are you finding some changes in this Megaevent this year? Some changes you have found?
Yes, yes.
Some improvement? Yes or no?
Yes, yes.
You want better improvements? You want sometime TDMPA to go to Dadoji Kondev Stadium?
Yes.
Really? Go on supporting TDMPA and all the sponsors like this. And let me tell you friends, days are not far off. TDMPA should act as a leader for all the medical associations. Thank you. Give big clap.
So first prize,
Aladdin ka matka.
pulse oximeter